Hello, I'm Dr. Shlomit Schaal. Welcome to our Women in Surgery webcast. And today I have a pleasure of hosting Dr. Mary Brandt. She's the Emeritus Professor of Surgery, Pediatrics, and Medical Ethics at Baylor College of Medicine. Welcome, Mary.
Thank you. It's so nice to be here.
Tell us a little bit about yourself.
Oh, my goodness. I'm not sure exactly where to start. I have been in the medical center a very long time. I went to Baylor for medical school. I did my general surgery training at Baylor, including a lot here at Methodist with Dr. DeBakey and many of the other surgeons here. Went to Montreal for pediatric surgery and then came back and pretty much was on the Baylor faculty and working at Texas Children's as a pediatric surgeon for the rest of my career.
So you worked with the famous Dr. DeBakey.
How
was that?
I did. Oh my goodness, there's so many stories. And many of them are legendary and most people don't believe they're true, but they are.
Tell us one story.
Well, two things. When you're a junior resident at that time in the program, you started off as an intern as the X-ray resident or the floor resident, and your entire job was inpatient, but it was either organizing the X-rays for him to see every morning and making sure that the coffee was made with the decaf on the left. I probably could still do this. And two sharpened pencils, the red one on the left, next to his patient list, so it was there when he walked in.
So this was what year?
This would have been 1983, 4.
So no electronic medical records.
No.
It's pencils, and then it's X-rays that you don't see on the computer. You look at the X-ray.
With the X-ray.
And that was your job.
That was the job of the interns, that and managing the patients on the floor.
So how many women before you did that job?
There were only 2 women before me in the history of the program. So I was the third woman. No women during the 5 years I was doing it. And if you didn't get fired, and I say that actually very deliberately, because if you made even a single mistake, Dr. DeBakey would fire you on the spot.
And fire you as a resident? You're no longer a resident?
Gone. Yeah, so my class actually started with 11. It was supposed to go to 8, so it was a pyramidal program, so we knew 3 of us would be gone.
Wow.
But we ended up with 5 because he fired 5 people.
Wow. So how was it for you? I mean, and how did he treat you as a female? Were you treated any differently or not?
The answer is yes, but in retrospect, I think it wasn't necessarily even gender. There was very much this idea of what a surgeon should look like, who they should be, and that had to do with race and ethnicity and gender and everything. However, if you could do a good job, that was noticed. So for a long time, I told people that it was equal opportunity torture. It was, it didn't matter if you were male, female, or anything in those first years. If you met the bar, then you weren't woman, man, you were surgeon. And they treated you that way. And that was for the most part true.
So on those times, there was no protection of hours for the residents the way there is. So you basically lived in the hospital with your co-residents?
Yes, pretty much. We were absolutely doing 100-hour weeks. And then, of course, there's the famous ICU rotation, where the surgery residents checked in on the first day of the month and left the last day of the next month.
Wow.
So I did 61 days minus 1 hour for daylight savings times when I did that rotation.
Wow. So you graduated, you survived, I guess.
I did.
Which, 50% of your class did not, and you did. And then how did you feel? Why did you go to pediatric surgery?
I think at the time it's very interesting because cardiac surgery was by far everyone else in my class went into cardiac surgery, put it that way. And certainly coming from Baylor, we were not expected to, but it was the pinnacle. And pediatric surgery at that time was the poorest paid, least respected. Dr. DeBakey actually wrote me a letter of recommendation for my fellowship. But when I asked him, he said, well, I'll write you this letter, but it's an unnecessary specialty.
Wow. So why did you choose that?
It chose me. I think, in pediatric surgery, we talk about saving lifetimes, not lives. But I think a big part of it is it's never the child's fault. So getting up at 2 a.m. to take care of a child, it's never their fault. So the chance of burning out or becoming cynical, I think, is less. And I think pediatric surgeons in general are a much more satisfied, happy lot.
So you went and did that in Canada?
So the year I applied, there were 17 positions in North America. So there's not very many pediatric surgeons. There's still like 1,000, 1,200 of us in the United States. So small specialty. There were 2 in Canada at that time, and this was or there were 3 actually, but this was in a French-speaking hospital.
Yes.
And I speak French because my father was an exchange professor in France. So I had this amazing opportunity to train in this huge hospital with a large number of attendings who were from Europe, from Canada, from the United States, and it was exceptional training.
And this was in Montreal?
This was in Montreal.
Oh, fantastic. The food is also better.
Yeah.
And then you come back.
Then I got recruited back to come back to Baylor and started my career at Texas Children's.
And then you became like the chief of the Department of Pediatric Surgery? Or?
I never did that. I worked for Bill Picornia and Jem Harburg, so it was just the 3 of us to start with, and it's grown into 20.
Huge.
Yeah, it's huge now. So never was chief in pediatric surgery, but sort of veered off into education and some other things as time went on.
So how is the training in pediatric surgery is different than adult? I mean, I think a special population, even today, of surgeons go and treat kids. So how is it different in practice? I know many, young physicians are watching us and they're wondering, is it different or the kid is just a smaller adult?
No, children are not just little adults. We have to say that. That's part of our training. We have to sign a thing that says we say that every time we give a lecture. It's interesting because it's the last true general surgery. So you really have a lot of operations that you have to learn, a lot of diseases that are different than adults. But most of this is about the congenital anomalies. And so you have to understand the whole spectrum of how things can go wrong in development in order to be able to repair them. So there's an intellectual challenge. There's certainly a technical challenge, lots of emotional challenge. But in general, I would say people that go into pediatric surgery are well-grounded and nice people. And I think that's because you couldn't go to work if you were mean. Your patients would be yelling at you all the time, going, "You're so mean."
So as a contrast to general surgeons that can be mean, and that's okay.
They shouldn't be, but
they shouldn't be.
Yeah.
So gentle also, physically with the body that is smaller, and I can imagine that over the years you had to operate on younger and younger babies just because of the advancement in medicine.
Absolutely. I think the smallest baby I ever operated on was just under 400 grams.
Wow.
Yeah.
What was that surgery?
It was a necrotizing enterocolitis, so intestinal surgery.
Wow.
Yeah.
So a newborn in the NICU.
Correct. Yeah.
Wow. So, but that's really saving, what is it, like 90 years of lives?
We hope.
Yeah.
Yeah.
Amazing. Yeah. So you went to the educational side. How was that? Was it a conscious decision to really educate and influence the next generation?
I don't think so. I think it's very interesting, and this is something I try to tell as a mentor to people, that so much of how we move in our careers comes about because of these moments. There's this kind of moment in a path where you do something and somehow it changes the trajectory. And I started off really as sort of a classic academic surgeon with NIH grants and doing basic science and clinical science, and ended up getting pulled into education 2 ways. One was helping negotiate a kind of mini crisis with the residents. So I had interacted a lot with them. I think they trusted me. And at a point where there was a standoff in the department, I stepped in to try to help solve it. And you got to watch what happens when you do that, because the next thing you know, they're asking if you want to be program director.
And you became the program director.
So I became the program director. But the other thing that happened was I started teaching embryology, which, pediatric surgery is applied embryology.
Right.
And that came about because Claire Huckins, who was a friend and my professor who taught me embryology as a medical student, ended up becoming ill. And she called me in her office and said, we talked about you doing clinical correlations, but I want you to teach the course. And I'm like,
Wow.
So, the first year I did it, I've estimated it was somewhere between 20 and 30 hours per hour lecture it took me to get ready,
Yeah.
because I had to learn how to teach gastrulation and things like
Yes.
that,
Amazing.
But it ended up being one of the true joys in my life to teach that course and to interact with the first-year medical students right after they arrive.
And then the ability to actually translate it into clinical care, right? To give them
Yes.
examples and stories. That's amazing. Usually embryology professionals cannot do that.
Yeah.
That's amazing. And so you became the program director. And how many years were you program director?
Gosh, I'm trying to remember. It's 5 or 6, because then I went on and I was asked to be Dean of Student Affairs.
So you became responsible for all the students in it's Baylor College of Medicine.
Right.
And so what have you learned in that about students, about learners in general?
Oh gosh, that's a great question. Everyone when they first start in medicine, they're so excited, they're so altruistic, it's the brightest, most motivated, resilient group of people you'll ever meet in your life. And I think the rest of my trajectory, which I know we'll talk about, came about because I watched these students and residents all of a sudden kind of fade into, a lot of angst and depression, and there were even some suicides. They were just derailing. So these super bright people who were so motivated, and there's a percentage of them that just derail out of their career. And I started talking about this and thinking about it 20 years ago with a group of people who were just starting into the physician wellness studies and thinking about it. And there wasn't an answer. It's like we just kept saying, do more yoga, be more resilient. And now we look at that and say, well, we totally missed the mark, totally.
So this happened over the course of the years, and it's interesting. And at one point of my career, I was thinking maybe I would be dean, and I did a dean's fellowship where I shadowed different deans of medical schools, and they said exactly the same thing that you're telling me right now. And they said maybe, with the way we educate our kids before medical school and how it's difficult to get into medical school and you're focused, and maybe when they come they're already burned out even before they started. So what do you think?
I don't think so.
So what do you think?
I think that I'll be a little controversial maybe and say it this way, that we've sort of approached a lot of the wellness issues as looking at the cracks in the wall and putting paint on them. But we actually have a problem with the foundation. And it's really more about the why we do what we do. And I think what we've done is we've taken people who want to learn to be healers and put them into an environment that is highly regulated, highly business oriented, and there's a disconnect. And unless you can figure out how to navigate that, you're sort of out of alignment. And I think somewhere in there is where the fundamental issue is.
So that's interesting, because the burnout, and I know now you're speaking about this all over the country, but the burnout actually begins in medical school. Before you enter the real world, if you will, before you have real responsibility for patients' lives. So, I remember different results of different burnout or wellness studies in medical schools, and about 20% of the medical students were already burned out. So how do you explain that you're still learning?
But it starts in the clinical rotations. Okay, so the stress of exams and all of that, there's a whole component that's just in a high stress graduate school education, right? But when we're talking about this kind of moral distress that leads to the kind of burnout we're talking about, it's arriving in the clinic with this idea of what a doctor should be, what a healer should be, and then watching the things that we've seen, watching people be turned down because of their insurance, watch the conversations in the lounges and among doctors be about how horrible this is and about money and business and fighting with administrators or, whatever it is. The conversations are very rarely in those situations about the joy of healing. and what we're actually doing.
So you became interested in that in your role as Dean of Faculty Affairs. You became
Dean of Student Affairs. Yeah.
Dean of Students, right? Even
Yeah.
better. Okay,
Yeah.
directed towards the students. So you became interested in that, and then what did you do about it?
So I started working, 20 years ago with other people, and sort of, people talk now about the stages that we've gone through in physician wellness. And Tate Shanafelt, who's
Yes.
really one of the great leaders in this, talks about the time that I trained as being the era of distress, right? And then there's wellness 1.0, well-being 1.0, which is that whole period of time, probably the first 10 years I was doing this, that was about resilience and about how we need to sleep more and eat more and do that. But it sort of took it and pointed at the physicians who were so injured themselves and said, you just need to be better at this.
You're not strong enough.
You're not strong enough, right? And that never made sense to me. I mean, it's a huge, resilient group of people. And then we sort of began to realize, you know what, there's something a little bit more here. And so what Tate Shanafelt talks about is going into Wellness 2.0, which is where we really work together with administration, recognizing that physicians, sort of like astronauts, are human beings that have all these limitations, and as they should, that they need rest, they need different kinds of support than we're giving, and it's not just a business. And so that's the goal. I'm not sure, particularly in the United States, and I think we are a little different than other countries, how easy that's going to be, because administrators and hospital systems are under huge pressure. The structure we've created is so immense, the business side of medicine, that I'm not sure we're going to be able to negotiate that and have that happen.
So you'll be glad to hear that here at Houston Methodist, we have what we call the Jimmy Initiative, the Joy in Medicine Initiative. We call it Jimmy because this is Texas, and Jimmy is a Texas name. And we are really prioritizing joy in medicine in our physician organization. So that's why I wore green today, because green is the color of wellness. And we have a whole team called the Professional Fulfillment and Experience Team, facing the physicians and really trying to figure out what we can do better as an organization to make sure that we are the best place to take care of people. So it's not about only the patient. Of course, patients are in the center of everything that we do, but really the providers, the physicians and APPs and PhD clinicians that take care of the patients, how we can meet their needs. So we are doing something about it.
So you are actually what Tate Shanafelt would call a vanguard institution, somebody that's actually trying to figure out how to bridge that gap and do it.
So I'm inviting you to our Jimmy Symposium.
I know, and I accepted already.
Okay, good. Tate Shanafelt was one of our speakers last year in our inaugural symposium. So, and actually we have also a podcast where he is a guest and he's speaking about these things. But I think, you're absolutely right. This is not a problem that a physician themselves can solve. We really need to work together as a system and organization to figure out what works. So what did you find that works?
So I think, if you look at the spectrum of organizations and how they're dealing with this, I do recognize that Methodist is very high on that list. And there's a few other really good examples like Stanford but they're big centers with lots of resources compared to a lot of other places. And in my role now, sort of as a counselor and mentor to physicians, there are places that it is just brutal. That there is not only not this, it's almost the opposite in some respects. And so I think we have to be aware that across the country, as we're talking to physicians, this is what we're aiming for, but it's not happening in the majority of places.
So when you think about your own residency training with Dr. DeBakey and living, months at a time in the hospital, this was not wellness at all.
No, it wasn't.
And so I don't know how many people were burnt out then.
It's a very good question, right? Because we were exhausted, but there was also a different sense of why we were doing it, and a different culture around patient care. than there is now. And I'm still working trying to figure out how to articulate that and think about that, because in no way do I want to justify, living in the hospital for 2 months. I mean, that's crazy. But there was something conveyed about the patient being absolutely first, and that what you were doing was meaningful.
And you think our physicians now don't feel the meaning or don't feel as much or strong enough?
I think what happens, and I can only speak for myself, but if you look over the last 10 years, I think if you go into most departmental meetings, and perhaps not here, but in a lot of places, or anytime there's a group meeting and you have an agenda, at the top of the agenda and all the way down will be the budget and the timing and the OR time and the details. And there has not ever been this focus that it feels like there used to be, of people who stood up and said, what we're doing is actually really noble. Hard as heck, really hard, but it's really important and really noble. And I think those words matter, and the culture that conveys that matters even more.
So, we went to what we call the Jimmy tour, and we went from clinic to clinic, from area to area, and we actually met our physicians face to face. It's myself and my whole team, an executive team, and part of them are administrators, and talked to physicians. And exactly what you said when we asked the question, what brings you joy, right? It's the Joy in Medicine initiative. What brings you joy? In 100% of the rooms, and we've been in more than 25 rooms right now, 100% of them, somebody stood up and said, what brings me joy is to be able to provide great patient care and get great outcomes for my patients.
Yes.
And this was said every single time.
Yes.
And I would say, 100% of the room, people said, I want to start on time, have all my patients come on time, and go home on time. I bet that was not there when you were a resident or a young attending.
Well, I think no, I think it was a little different. It was kind of apples and oranges. There's been a lot of changes, but I think this idea that I want to be a whole person, so that I can bring my whole self and my healthy self to work to do this job that's so meaningful and that gives me such joy. The generation that's coming up now, they get it. Yes. They really get it. And I think that's great.
Yeah, that's wonderful. And, I'm all in. I wholeheartedly believe that this is important. And what I saw about your resume is that you also went and got a degree in divinity. What's that about?
I did. So part of this journey and thinking about this really came down to when I think about the people that really derail and are miserable doing this wonderful work that they wanted to do their whole life. Sometimes it's that you've lost the context, you've lost the meaning, you've lost the why, And I didn't have a good vocabulary to try to talk to people and think about that. So I went to seminary to get a Master of Divinity degree to actually think about those bigger questions and how you could translate that into a world that's actually very scientific and very business-oriented, whether that was a missing piece that somehow would help us move forward.
And what did you find?
I think so. It gave me a lot of tools that and a lot of perspective myself that I think is helping a lot.
So I think one of the magic things about Houston Methodist is really the spiritual grounding of our institution and the way that we try, at least very hard, to create an environment of healing. So we have music therapy, we have prayers, we have chaplains everywhere, and even in our clinics and the physician organization, trying to really help people heal. Because to your point, the science and the facts and the statistics are important, but there's something beyond that, which is the healing process, and who is going to hold your hand through that very, very hard journey towards healing. And a lot of us are so busy, maybe we don't have time to do that. So who is going to do that? Maybe a chaplain, maybe a training for our physician in kind of spiritual care. I've never thought about it before.
No, that might be a good idea.
We have our kind of chief spiritual care, and Reverend Charles Milliken, that's his name. And he taught me so much about just listening. That comes, with their training as, chaplains and spiritual people. I do not know if I learned how to listen in medical school or in residency or in fellowship. I don't think anybody taught me how to listen.
I think that's a really good point. I was just talking to someone the other day who introduced me to this concept of fierce love, also called critical love. There's this whole theory. And in talking about this, the person that was talking about it said, you don't have to like your patients, but you have to love them. And we don't use those kinds of words or talk about compassion. It's like, so, spiritual care and what you are as a healer, if you're a retina surgeon or a pediatric surgeon or internist or whatever, those are not separate things, right? It's like, what am I bringing to this table as the person that's primarily responsible for what's going to happen to you, to let you know that I'm actually walking with you through this, that I have some expertise and I have some recommendations. I may do procedures, but I really care about you. I have compassion for you. And that's something that I think human beings naturally have. I think in the healthcare organizations of all kinds, healers of all kinds, that's part of our DNA. But if you have a culture that doesn't promote that and nurture that, you end up with, we have spiritual over here, we have the clinic over here, and that's not what patients want.
Right, you have to bring it together. So what is now your what would you recommend for me, for example? I'm leading a physician organization and I want us to have a kind of an army of healers and people who use compassion to heal our patients.
Well,
what do you advise?
So part of this is really just the shift in the way you think about it, right? So when I talk about this, and we have the era of distress and wellness 1.0, which was yoga and put bananas in the surgeon's lounge, and then
That's a good thing.
This is necessary, but not sufficient. So I'm not against yoga either. And then wellness 2.0, which really is let's work together, and which is what you're talking about. I really think that we're on the verge of what we need as a grassroots revolution. And I do believe the younger generation gets this and is looking for this even more. And when I've thought about it, to me, if I can get every physician healer, and so healer to me is anyone who's trying to make someone else whole. Okay, so that's a big group in a hospital and even out of the hospital.
That if not only physicians, everybody who works in a hospital environment is a healer, basically.
Yeah. So, and I don't use the word provider.
That's good.
Yeah, because I think it's a business term. Yeah. And when we use the word provider, we're actually excluding a whole lot of other people who are contributing to the care of patients. So I actually use healer as my
I'm going to take that from you.
Okay.
I'm going to use that.
So if we're working in an organization to try to have healers see things differently, I personally believe the grassroots revolution, if we have 3 things that everyone commits to doing, that will change it. And it's not committees and agendas and policies and all that. This is from the bottom up. So the first is compassion. And by that I mean practice compassion, like actually learn about it and learn the techniques for emotional regulation and how you listen and how the things that actually have you live compassion. So if we all commit to studying it and practicing it, the second thing is to say the truth. That, there's a lot of things that we say have to happen in our systems that probably aren't right. And the words that I've used in the past is to just look at something and go, that's really not normal.
For example?
Well, the example that came to me was an oncology friend of mine who, very complicated clinic with, these are people with new diagnosis with cancer, just huge needs. And they came, we were sitting talking over coffee and they said, well, the administration says I have to cut my clinic visits from 15 minutes to 12 minutes. And I can't even talk about cancer in 15 minutes, but I guess there's nothing I can do.
Oh.
And my response to that, well, there is something you may have to agree to that because that's who employs you, right? But you can say, that's really not normal. That's not what a physician who's counseling a family about a cancer diagnosis, you shouldn't have to worry that you have 8 more patients to see when this patient is falling apart in front of you. That's not normal. So I think if we can, normative might be the better word, but I think it's not as catchy for people to remember. So, if we all just can say to ourselves or to the person, that's really not normal. So we may have to do it, we may have to agree to it, but let's just not forget that that's kind of not how we define healing, right? And then the third thing I tell people is decide who you work for. Because who employs you is not necessarily who you work for. And I think for most physicians, particularly in academic centers, we work for our patients, we work for our trainees, we work for each other. We're employed by the hospital.
Right. That's interesting that you said, because in our Jimmy tour, another thing that our physicians told us, what brings me joy is my students, my learners, my residents. It brings me joy.
Yeah.
And yet it's not a money-bringing activity.
There's not a metric.
Well, there is metrics for everything, but I would just say, if you talk about the business side of things, education is important. Don't get me wrong.
Oh,
Super
totally.
important.
Research is in the same
but
boat,
it's not.
right?
Yeah, and research, to a lesser degree than education. But education, that was so important. And I'm listening to you, getting inspired by you as an educator, as a healer, and as even a spiritual leader. How do we compensate for that, or how do we encourage people to go into that, and how we give them the time to do that? So I think it's a very important point.
And I'm struggling with it myself, and I don't have a good answer, but the only answer I have is, how do you measure compassion? How do you measure love? What's the metric for that?
And there's a song for that.
There isn't one, right? I mean, there isn't a metric. Not everything can be measured.
Yeah.
And not everything should be measured. But yet it's the most important thing. So how do you create a culture where you convey that this is so important that maybe we won't even use the same kind of spreadsheets to figure out what to do about it?
Correct. So we are also revising our compensation plan for our physicians along those lines, because when the physician organization was formed 20 years ago, it was only about RVUs and clinical productivity. And fast forward to today, we need to find ways to support leadership, administrative roles, and educational roles, as well as research roles. And I think our system is not, designed to do that. Another thing I would say is that healthcare in the United States is so complex, and the way we get paid is maybe different than other countries.
I agree.
Do you know of a country that does it better than the United States?
So here's my perspective, and I know this will not be popular with a lot of people, but there is nothing easy about practicing medicine. Okay, when your job is to relieve suffering, that's a burden, right? So that's the same everywhere. So take that to one side. Secondly, in the last 30, 40 years, the explosion of technology and of new drugs and of expensive treatments, right, is worldwide. So worldwide, there's a lack of resources for the need. So that's automatically moral distress for healers who are trying to use something that they don't have access to. Okay, so that's worldwide. What is different in the United States, and this is where I will make some enemies, we're the only system in the world that has a for-profit component in our healthcare system. And it's probably somewhere between 6 and 8% off the top. And when you look particularly at companies that are paying shareholders, by law, they're required to pay those shareholders first before they reinvest that money into programs and other things in the healthcare organization itself. And then if you move one more step to something that I really truly believe is evil, is private equity.
Oh, okay. We can talk about that
because then you have the people that are profiting off of this who are completely disconnected from the work. And their only goal, and their stated goal, and their legal requirement is to do whatever it takes to make profit from this business transaction. And that's not healing.
So, I'm a retina surgeon, and so many of my colleagues now work for private equity. That's really, is pervasive in the field of retina surgery, even here in Houston. And I think about it a lot, how suddenly we decided to make money out of medicine and how medicine became a business. It is a business already, we have to grapple with it, but how do we, as to your point, choose to work in organizations that still have the missions and are really focused on the missions before they're focused on the profit?
But the other thing, and I know we'll wind up here, but I totally get it, and everyone gets no margin, no mission, right? There's nothing wrong with profit. It's not evil by itself. But when the margin becomes the mission is when you have the moral distress and you have the healers that can't figure out why they're so out of alignment, but they are.
But I would say no mission, no margin. It's not only no margin, no mission. I mean, what are you doing here if you're not after the mission? So what are you doing? Making money out of suffering? No, you have to have the meaning. So I think we're completely aligned, and I would love to talk to you for a very long time, but our time is up. It's such a pleasure to have you on our show today, and I'm sure many people will reach out to you or follow you, and everywhere we can. Come to our Jimmy Symposium. Would love to learn from you more. And thank you for watching. Join us next time for our next Women in Surgery.